Okay, so yeah, we're ready to go now. The first speaker in this almost exclusively online session is a friend of ours from the UK, Dr. Mo Tawfiq. Dr. Mo has participated in the last 3 meetings of the EDDW actively. He was there personally and even oversaw a training program done during the conference. Unfortunately, this is the first where he cannot attend in person, and let's hope it's the last time. So we're looking forward to this presentation. Dr. Mo is a consultant gastroenterologist and an expert colonoscopist and upper GI interventional endoscopist as well, and involved heavily in training. The first presentation will be given by Mo, who is not related to Salah, of course. Yeah, he's a Gunners fan, so unfortunately. So the presentation will be on the management of upper GI bleeding and evidence-based approach, which he will cover in 30 minutes.
Thank you, my dear friend. Thank you for the kind invitation and the introduction as well. Unfortunately, Arsenal's not doing well, but Mo Salah is doing well. Alhamdulillah. Thank you, and thank you very much to the whole team and Prof. Sarags and the team. I've just heard Dr. Mali give an excellent talk. I think you've already heard all the essentials that we need to look after when it comes to bleed, but I'll try and do my part as well. Thank you. Let me share my screen. Excellent. So I'm just going to try and minimize this. Yes, the topic I've been given is management of upper GI bleeding and evidence-based approach. So just a bit of a background about my talk. We'll talk a bit about the pre-endoscopy management. We'll talk about the timing of endoscopy. We'll talk a little bit about the intra-procedural factors. We'll also talk a bit about what we actually do after we've done the procedure. So how big is the challenge? We know that gastrointestinal bleeding is one of the commonest medical emergencies. Just from the UK, we know that we get about 1 patient every 6 minutes. So that's about 85,000 cases per year in the UK. More than 14% of all the blood transfusions given are for upper GI bleeding. So we need a lot of blood for these. Challenges still exist with regard to looking after the GI bleeds, that includes the whole service. We need skilled endoscopists, we need a process. We also need to have good training on board because we need to look after the future trainees and future consultants. So first things first, you want to know that you risk stratify the patients. You want to make sure that you prioritize the patients. You want to know if you have to escalate the patient to critical care. You also need to know when to scope. Just because the patient has been admitted, it doesn't mean that you get your scope out and readily scope. You also want to know, is the patient fit enough for an outpatient scope? You don't need to keep the patient in hospital. So to help you make this decision, there are several risk scores that are available for GI bleeds. And these include those that require endoscopy scores and those that are clinical scores. So the 2 commonly used scores are the Rockall score, which has the full complement of both clinical factors and the endoscopy factors, and the Rockall score, which is used based on the clinical presentations, and the Glasgow-Blatchford score, which purely uses clinical factors. So just a slide about the Glasgow-Blatchford score. The Glasgow-Blatchford score is very simple. This can be done before you start your endoscopy. The factors that make the score include the admission risk marker, that is your blood urea, the hemoglobin levels, the systolic blood pressure, the heart rate of the patient, and also the presentations and the history. So you can make a risk stratification without putting a scope down your patient. You could consider discharging the patient if the Blatchford score is 0 or 1, and consider an outpatient score provided there are no other risk factors for the patient. So clearly the Blatchford score predicts the need for intervention, i.e. transfusion or endoscopy. So what about the Rockall score? The Rockall score helps you to identify the risk of adverse outcome following the upper GI bleed, i.e. risk of mortality. Again, for this, although you need the endoscopy findings to do a full Rockall score, you could do your Rockall score purely also by using clinical factors that includes the age of the patient, the blood pressure, the comorbidities, diagnosis, and as I mentioned, you need the endoscopy findings to make a full score. This could be, you could remember this at 2 in the morning when you're looking after a GI bleed patient by simply remembering A, B, C, D, and E. So how is it useful? The Rockall score, as I said, predicts the mortality. So the more the Rockall score, the more likelihood that the patient will unfortunately die following the risk of following the upper GI bleed, i.e. if a patient has a Rockall score of more than 4, the risk of mortality is more than 25%, and the risk goes up. So you've not even scoped the patient, but you're getting the history, so that you want to know the history. Is there a history of coffee ground vomiting, or is there bloody hematemesis? Why is it important? This is important because we know that the patients who have hematemesis, i.e. bloody hemesis, have higher likelihood of rebleeding and also have a higher likelihood for need for intervention, suggesting perhaps you need to be focusing a lot on those patients who actually have bloody emesis than coffee ground vomiting. So it is quite important that you get a good history. I know some patients come in with photographs of what they've actually brought out of the mouth. It could also be useful. So how is it important to give resuscitation? We know that the patient needs to be ready before we actually scope them. So this study looked at 2 groups. One group was used as an observational group, and the other group was used as an intensive resuscitation. So the observation group had less intense resuscitation when compared to the intensely resuscitated group. And they compared the 2 groups' outcomes. The outcomes were risk of myocardial infarction or death. As evident by this presentation, in this slide, I can show you that the patients who were on the observational group had a higher likelihood of myocardial infarction or mortality, suggesting and showing the importance of resuscitation, suggesting that the care of patients with upper GI bleed should focus on early and rapid correction of any poor hemodynamic status. So the mantra, the take-home message should be ABC, which is airway bleeding and circulation should come before OGD. So what about pre-endoscopy PPIs? What is the evidence for it? The nice guidance suggests that it's best to avoid PPIs pre-endoscopy. However, the ESG, the European Society of Gastrointestinal Endoscopy, suggests that PPIs may be given pre-endoscopy whilst the patients are still waiting for endoscopy. However, it's also important to know that PPIs should not actually delay endoscopy. So what is the usage? What is the practice? We know that in the UK, a significant percentage of patients already take PPIs. I'm sure that is the case in Egypt as well. We also know from the TRIGGER study, which was a landmark study, showed that more than 50% of the patients received pre-endoscopy PPIs. We also know from our own experience working in critical care areas that acid suppression is a routine practice. They use it as a stress ulcer prophylaxis in all the critically ill patients. So what happens if you give pre-endoscopy PPIs? So this study compared 2 groups. One group had omeprazole as a PPI infusion. The other group had only placebo. And the two groups that were looked at were the high-risk groups and the low-risk group. It was found that the patients who were on the omeprazole group had lower percentage of findings of high-risk lesions, i.e., as Mally mentioned, they had a lower likelihood of actively bleeding ulcer, less likely to have non-bleeding visible vessel, less likely of having clots, suggesting that giving PPIs pre-endoscopy may actually downstage the lesion, i.e. they push them into a lower forest lesion recognition, i.e. they also may need less need for endoscopy therapy. However, it hasn't shown to reduce mortality, rebleeding rates, or need for surgery. What about PPIs post-endoscopy? There is strong evidence to suggest that giving PPIs post-endoscopy reduces the need for surgery, reduces the risk of rebleeding, need for transfusion, and the length of stay. However, there is no reduced overall risk in mortality. So what about terlipressin for acute variceal bleed? There is evidence to suggest that giving terlipressin pre-endoscopy and for the treatment for acute variceal bleed does reduce mortality, both the inpatient mortality and also delayed mortality. There is also evidence to suggest that giving antibiotics in the context of variceal bleed also reduces mortality. Tranexamic acid, as evidenced by the recent publication from the HALT-IT trial, has not shown an overall improvement in the evidence of an upper GI bleed, although there are still evidences to suggest that it could be useful in some cases, but not in all cases. What about blood transfusion? We understand that there is a widespread variation in the use of blood transfusion. Some studies have shown that excessive transfusion may actually increase the risk of rebleeding. We also know from the UK-based audit of the GI bleed showed that over 50% of patients were transfused if the hemoglobin was between 80 and 100 grams per liter. The question arises, should we do a restricted transfusion or a liberal transfusion? So this is answered by the trigger study, where the patients were either randomized to two groups, where they were transfused when the hemoglobin was less than 80. So that was called as a restricted group, or a liberal transfusion, where it was transfused when the hemoglobin was less than 100. What was found? There was no significant difference in the clinical outcomes. Certainly, this study showed that a 13% reduction is achievable by using the restricted transfusion. What about in the context of a very severe acute upper GI bleed? What is the evidence to give restrictive transfusion? Restricted transfusion, when compared to the liberal transfusion, does show that perhaps these patients will have a reduced risk of rebleeding, reduced risk of adverse events, and also risk of or likelihood of survival is much higher. Now the question arises, what is the time to scope these patients? The NICE guidance suggests that we should scope these patients immediately as soon as you resuscitate them if they're unstable. And all patients should be scoped within 24 hours after being admitted or having the presentation if they're already an inpatient. There is also a suggestion that units which have more than 330 cases per year should have provisions to do these cases on a daily basis. And low-risk patients should be discharged for an outpatient procedure. The ESG guidance also stratifies this in terms of very early endoscopy, which is less than 12 hours, early endoscopy, which is less than 24 hours, and delayed, which is more than 24 hours. So what is the evidence? Does early endoscopy improve the outcomes? So for this, we have to look at the various randomized controlled trials, which looks at patients who were scoped with less than 12 hours, less than 2 hours, or less than 6 hours. None of these studies have shown any evidence of benefit from a very early endoscopy. So what about patients who actually are hemodynamically stable? What is the best time to scope them? For this, we look at this study, which looked at the timing of the scope after they were admitted and looked at the mortality. So doing them early, even in a context of a stable patient, may actually increase the mortality. Likewise, leaving them too late also increases the risk of mortality. So doing them between 12 to 36 hours in a context of a hemodynamically stable patient perhaps was considered as optimal. The same study looked at the unstable patients, and likewise they found that doing them between 12 to 24 hours perhaps is the optimal time. All these suggest that it is important to resuscitate these patients, optimize the patient, make sure they're ready for the endoscopy. So what about based on the Blatchford score? Because the Blatchford scores are quite useful. So we could perhaps say that the Blatchford score of more than 12 perhaps is a high risk. So if you classify and put them into either urgent endoscopy or an early endoscopy, which is within 24 hours, and also find out what happens to them. Do they actually rebleed more? Is there an increased risk of mortality? Based on this study, we know that early endoscopy in a context of a high-risk patient within 24 hours is pretty reasonable. It does not increase the risk of rebleeding or mortality. This is our own study, which was done in Sheffield. Sorry, it's a very busy slide, but I'll try and make it simple for you. We looked at two groups of patients who were either low risk or high risk. The high risk were those who had a pre-endoscopy roll call score of more than 4. So if you remember from my first few slides, this group will have a nearly 25 to 30% risk of mortality. We classified them to have an early, we looked at it retrospectively and saw if they were actually scoped early within 12 hours or delayed. We didn't find any difference in the risk of rebleeding, need for a repeat intervention, 30-day mortality, either in the low risk group or in the high risk group. So how are we doing in terms of time to scope as a country or as a region? So this was a UK-based regional study which was done in the Midlands, and they looked at how we are as a region doing in terms of scoping these patients within 24 hours. This is the time from admission to endoscopy, and these are the various hospitals in the region. And this is all 24 hours, and you can see not all units manage to do endoscopy within 24 hours, suggesting there is a serious challenge in looking after these patients. So which are the patients who are less likely to have delayed endoscopy, i.e. they were scoped early? These were patients who were admitted out of hours, who had suspected variceal bleed, or if they were hemodynamically unstable, had a higher Blatchford score. And again, it is important that patients are put nil by mouth when they actually come in, when these will reduce the likelihood of delayed endoscopy. So moving to the question is, why do patients actually die when they present with an ulcer bleeding? For this, you have to look at this Joseph Stung study done in 2010, which looked at over nearly 10,000 patients who had GI bleeds and found that actually the risk of dying from a bleed itself is very low. The likelihood of dying is more from a non-bleeding cause. That could be from a comorbidities, which might be malignancy, or they have a multi-organ failure, pulmonary disease, or a cardiac disease. So the question arises, is it safe to continue aspirin in a context of an upper GI bleed? Because a lot of patients may actually have a thrombotic event. For this, you have to look at
I'm afraid that the timing is 15 minutes only, not 30 minutes. Sorry for this inconvenience. So I will give you 2 minutes to wrap up your lecture, just because we have other lectures. Thank you so much for understanding.
Apologies, I was told that it was 30 minutes, but I appreciate and respect. So I shall wrap up with showing a few essential, my tips, to top 10 tips for decision making. It's important to know what is the history. Is it coffee ground or hematemesis? What is the risk, i.e. risk stratification? What are the comorbidities of the patients? The resuscitation. We need to know when to scope, where to scope, what pharmacological therapy may be given, when to give blood products, and what kit needs to be ready. And I think I haven't covered that today, and I couldn't cover the personnel needed for the procedure, but I'm sure the next presentations will cover that. In conclusion, I would like to say that upper GI bleeding is a medical emergency. Pharmacotherapy and endoscopy have a significant roles in the outcomes. There is a UK-based bundle which does aid in the management. I'm happy to share that with you at a request. Aim to scope all patients within 24 hours of presentation. Training has a significant role in improving skills. Thank you for listening. Please contact me if you have any questions.
Thank you so much, Professor Tawfiq, for this illustrative talk. And now we move to Professor Ali Farag, Cairo University. He's going to give us a talk about fundal varices, tips and tricks you need to know.
Dear colleagues, Assalamu alaikum wa rahmatullah. I'm going to talk about the other side of the story, the varices. To start with, we have a problem. We have less gastric varices than esophageal varices. However, this is yet associated with higher mortality. Gastric varices are very peculiar. They are different from esophageal varices for sure in everything. My aim today is to let you know the basics of gastric variceal treatment and to give you simple tips and tricks to deal with such patients. Gastric varices are about 20% either alone or with esophageal varices. They are quite different from esophageal varices, and these are the differences. They are more extensive, they lie deeper in the submucosa. The mean portal pressure is lower than the pressure in the esophageal varices. Their wall is thicker, they are larger, and this results in higher tension in the walls. They have fourfold increase of the possibility of bleeding, and the mortality is much higher. The estimated mortality is up to 40%. They are classified according to serine into either isolated, the ones down, or the gastroesophageal, the ones up. They are different anatomically. In the case of esophageal varices, there are a connection between the left gastric and the azygous system. However, in gastric varices, they are quite different. They take their blood supply from the splenic vessels and the short gastric varices, either alone or in association with a shunt between the left renal vein and the gastric varices. The standard endoscopic treatments, mainly of the sclerotherapy and band ligation, don't work with gastric varices. And let us see some of these varices and how they look like. This is an example of isolated gastric fundal varices. This is an example of the GOV1, those extending from the esophagus to the lesser curvature. This is different shapes of the varices. That's another shape of the varices. But the most one, and this is just like grape, the most fearful one is this one, which looks like a spider with too many legs. The main thing in resuscitation, pharmacotherapy, and antibiotics are almost the same like esophageal varices, but the difference is that the idea of treating these varices is either obliteration or decompression. We can obliterate them by several methods: the cyanoacrylate injection, the injection of thrombin, PRTO, EOS guided coils with or without histoacryl, or to decompress them with TIPS surgery or liver transplantation. The one I'm going to talk about, because the most commonly used in Egypt, is the cyanoacrylate use. Cyanoacrylate is actually very, very efficient in stopping the bleeding, almost 90%. The rebleeding rate is about 20% within 1 year. Let us thank two persons who are really the basis of this procedure in Egypt. Professor Suhendra, who introduced the variceal bleeding stopping by histoacryl in 1986, and his dear friend, Professor Mazin Naga, who introduced this procedure very early in the 80s in Egypt as well. These are some of the tips and tricks you can use when you see such patients. First, you be calm, because it's a stressful condition. If you just lose your nerves, it's the worst thing. But if you keep quiet, it's a very simple procedure forward. It's a teamwork. You have to train your team, because you can't work with a team who is doing this for the first time. This was one of my teams. Patient position is very important. We usually put the patient in the semi-prone position, just lying on his abdomen. Why that? Because this makes the fundus with the bleeding point higher up, and the lake of blood, as you can see to the right down here, so that you can see the varix. And even if you have bleeding while you are doing this, the bleeding will go away from your scope, so you can still have some field to work with. The next step is test the scope and the accessories, because you are doing the procedure in the retroverted position. If you are using a scope which cannot do retroversion, then you are in a mess. So test your equipments nicely. See if you have the histoacryl, the cyanoacrylate, the injectors, and not only one injector. Cyanoacrylate is just like this to the left side. It's a 0.5 ml ampoule, and the injector of different kinds. Look at this video. When you put the cyanoacrylate in water, it solidifies. However, when you put it on blood, it makes something very peculiar. It crystallizes, hardens immediately. That's what's happening with the injection. We use the Libidol, 0.8 milliliter, to make the histoacryl less likely to clog the injector. Get near to the varix as much as you can. The nearer you to the varix, the more you'll be able to inject it. Use radiology if you can, because when you use radiology, it can show you where the injection is going, as in this patient. If you inject submucosal, you will see the difference. Your scope is very precious, just take care of it. If you try to do retroversion while introducing the injector, most of the time it will puncture the inner sheath of the scope. So first we straighten the scope, we get our injector out, and then we do the retroversion. In this way, we'll keep our scope healthy. Use one ampoule per injection. Don't inject two ampoules together, because this increases the liability of embolism. Palpate the varix after you inject, making sure that it's very hard. Repeat if needed with another ampoule. That's how you do it. Get near to the varix, straighten the scope, get your injector out. As near as you can to the varix. After injecting your ampoule, just be quiet for a minute or two, because it takes time to solidify. If you don't do this, you will use more than is needed. This very big varix just needed only one ampoule to be solid. If you just wait and palpate it again, you will find it as hard as a stone. Obliterate all tributaries. If you find a varix like this, you have to inject both sides. And usually we inject the more proximal one before the distal, because if you do the other way around, you will not be able to go to the one in the cardiac. So inject this one first, then inject the other one. Inject a healthy part near to the bleeding point. If you have a bleeding, don't inject exactly at the site of bleeding. It's unhealthy mucosa. So inject on another side away from it. And most of the time, the histoacrylate will come from the bleeding point and the bleeding will stop. Modify injection sites as required. I mean that in this patient, I can see the fundal varix from the forward view better than the retroverted. I can inject it from the esophageal side. I can do both if needed. So now we inject it from the esophageal side in the forward view. And then we can complete our injection from the other side. Scope within a week after the first procedure to be sure that your fundal varix does not need any more intervention. Most of the time you will find that it's ulcerated like this, but you have to palpate every other part of the varix to be sure that everything is as hard as rock. The commonest complication is thromboembolism. How can I prevent thromboembolism and avoid thromboembolism? Just by avoiding overdilution of the histoacrylate. Just give one ampoule per injection. Use a moderate speed of injection. Too rapid, embolism. Too slow, it will clog the injector. Avoid excessive flushing. If you found a gastric varix which is not bleeding, what can you do? Most of the guidelines say that you don't have to do anything, just add beta blockers. But one of the studies have shown that if your injective is with histoacrylate, it's actually better than giving the beta blockers. This is something for the future. If gastric varices secondary to splenic venous thrombosis, consider a splenectomy. You don't have to inject it. So the take-home message is that dealing with gastric varices is always exciting. The main treatment in Egypt is cyanoacrylate injection. In Japan and USA, there are many other methods. I hope that the previous tips and the tricks would help you next time you see a varix to treat it in a better way. Thank you.
Thank you, Professor Ali, for these very precious tips and tricks. I'd like to add just a few tips to what you have said, that in case of flushing the needle after injecting histoacrylate, don't inject too much diluted water in the needle, because it washes away the histoacrylate to remote areas and causing embolism or thrombosis. You have to train your assistant about the rate of injection. As Professor Ali said, don't inject very slow for fear that the needle will be clogged from if the rate of injection is very slow, and don't inject flush. Don't inject very fast, because for fear of away. One last tip that you have to train your nurse not to withdraw the needle through the biopsy channel. It may block it. Just get out with the endoscope and the needle out from the endoscope. Just wipe it and wash it, and then remove it from the endoscope. Thank you very much, Professor Ali.
Thank you, Professor Ali, for this elegant and nice tips and tricks regarding the gastric varices. And now we are going to move to our next speaker, Professor Amr Nasser from Cairo University. And he's going to give us a lecture about interventional radiology in upper GI bleeding.
شو عنوانه هو؟
So I would like to
عنوانه
invite
شنو؟
أكيد
محاضرتك عن عمل
لا تقول أعمل
Hello. Good evening, everybody.
good evening, Dr. Amr. We can hear you. You can start your
Yeah,
presentation.
there was an advertising appearing on the screen, so I was delaying my talk. It's a pleasure to be with you. I'm going to share my presentation with you. It's about role of intervention radiology in acute GI bleeding. GI bleeding is classified into the upper and lower GI bleeding. As we always know, it's according to the is it either above or below the ligament of Treats. The major causes are peptic ulcer, erosive esophagitis, esophageal varices, and sorry.
Excuse me, Dr. Amr, could you please share with us your slide of the presentation because we can see the presentation.
I'll go back again.
You can just press share screen and your presentation.
I press it, I'll go again.
Also, yeah, now we can see it. Okay, continue.
Okay, well, this is only the first slide I showed. It's regarding the gastrointestinal bleeding, upper or lower, okay, above the ligament of Treats, or below. According, it is below the bleeding is classified. Is it upper or lower according to is it either above the ligament of Treats or below the ligament of the Treats? The causes are peptic ulcer disease, erosive esophagitis, esophageal varices, arteriovenous malformation, Mallory Weiss's syndrome, and if there is any cancer or in the GIT. Also, it can be classified as you all mentioned, and we know that non-variceal bleeding or variceal bleeding and the uncommon causes. The most common is peptic ulcer disease, Mallory Weiss's, gastritis, esophagitis, arteriovenous malformation 5%, and tumor 2%. The variceal bleeding, the famous isolated gastric varices, the gastroesophageal varices in 90%. And the uncommon causes, hemophilia, De La Foy, and GAVE. GI bleeding is always a major medical problem, which can be a life-threatening, as we all know. So in any suspected case of upper GI bleeding, hospital admission is the first step to be done. Intensive care if it is needed, and start a proton pump inhibitor. If there is any evidence of suspected variceal bleeding, we will go, the next step will be endoscopy, and it would be the first step, the same as if it is a non-variceal. If endoscopy went okay, it will be good. Every bleeding will go for interventional radiology for the TIPS application. In non-variceal bleeding, such as peptic ulcer, which is the common cause, either we are able to stop bleeding, this is a good scenario. If not, we will go for arteriography and embolization. If not, we will go for the next step and go for angiography. And if there is no source found by endoscopy, we will go for arteriography and embolization. So upper GIT, as we can see, is a major dilemma. How we can go, we are going to display some of interventional procedures that can help us in this dilemma. We will start by non-variceal bleeding. First case is a male patient, 50 years old, with recurrent attacks of melena and recurrent onset of hematemesis. There is deterioration of the conscious level with hemoglobin dropped down to 7 grams. ERCP revealed the duodenal ulcer with severe bleeding and failed to control the bleeding. Urgent arteriography was requested to define the source of bleeding and to embolize if it is possible. Our rationale in every non-variceal bleeding case is to go for both the mesenteric and the celiac angiography. So we go for mesenteric angiography, early arterial, a little bit late arterial and late arterial, and the mesenteric angiography showed no significant abnormality or no bleeder. We go for celiac and celiac and the gastroduodenal, the hepatic, we go selectively, hepatic and the gastroduodenal, and we couldn't find a source of bleeding. Would we consider this is a negative study? And are we missing something? Yes, definitely. This is not a negative study. And we shouldn't complete every case, every similar case, to go selective into the gastroduodenal artery. To take magnified and oblique views. This is a selective examination for the gastroduodenal artery, giving the superior pancreatoduodenal and the right gastroepiploic. And if you just focus, you will find a small contrast pit here, which is the contrast from the bleeder. This is a GDA. This is a subtracted images. We subtracted the bone. It's clearly show the bleeding vessel. The diagnosis was the bleeding duodenal ulcer. There is some special anatomical consideration in treating such in this place, that we have the superior pancreatic duodenal from the celiac trunk from the hepatic artery and the inferior pancreatic duodenal and doing the arcades from above and below. If we have an ulcer in such location and we embolized either by coil or whatever, we occlude the gastroduodenal artery, there will be sharing from the inferior pancreatic duodenal and the bleeding will not stop. So the policy in such cases is to go for occluding the gastroduodenal, what we call backdoor, front door technique, to prevent bleeding from the inferior pancreatic duodenal and to stop the ulcer completely. And this is what we have done in our case. We occluded the gastroduodenal artery, and this is control images show disappearance of all the arcades, giving the bleeder in the duodenum. Clinically, the hematemesis started to decrease shortly after the technique and stopped 24 hours later. Melena reported to be trivial after 48 hours. Next case, male patient, 57 years with hematemesis and melena. Endoscopy revealed the bleeding duodenal ulcer. The bleeder was identified and endoscopic clip was applied to the bleeder. The patient continued to have hematemesis and melena, and the hemoglobin reached down to 6 grams. Urgent angiography was requested. Here we can see this is an GDA, gastroduodenal artery angiogram, and we can see the clips put by the endoscopy, and we couldn't find a bleeder same as the one we saw it in the last case, but we can see some corkscrewing We went more selectively in the posterior superior pancreatic duodenal artery. We didn't find anything. And the anterior branch, and also we didn't see anything except for this corkscrew and arcades. We go and embolize the anterior, we go and embolize the anterior superior pancreatic duodenal artery, and we can notice that such corkscrew arcades have been obliterated after applying of a coil. Are we satisfied by this outcome? We were not satisfied by this outcome because we didn't find a bleeder. But this is, you can see, this is the pre-embolization images, and this is the post-embolization images with obliteration of the corkscrew vessels and the abnormal vessels. Clinically, hematemesis stopped. Melena started to decrease and stopped after 48 hours. The patient condition stabilized. His hemoglobin started to rise, reaching up to 9 grams only in 5 days. So, not all the things you dislike are bad. Some of them are very effective and controlling. A third case, young man with past history of ERCP, stenting prior to cholecystectomy, with recurrent attack of melena. CT for the abdomen was done and revealed a pseudoaneurysm from the right hepatic artery branch. Angiography was done. This is selective angiography of the right hepatic artery. You can see as the pseudoaneurysm increased by time, and this was the cause of hemophilia and bleeding from this patient. We go super selectively by a microcath. We put a linear coil. Filling of the aneurysm is much reduced, but still there is filling of the aneurysm. We take off the microcatheter, take another control angiogram, still there is filling of the aneurysm. So we went further to the mouth of the aneurysm, and we started to inject glue, beta-cyanacrylate glue, together with the stent. And finally, you can see the difference between the pre-embolization images and the post. This is an early, showing total obliteration of the aneurysm and the artery, and late with no preferential filling. 50 years cirrhotic female patient during her workup for liver cirrhosis. She had a liver biopsy, after which she developed severe hematemesis. ERCP showed blood refluxing from the papilla with no duodenal ulcer or masses. Angiography was requested, demonstrated post-intervention arterioportal fistula. We can see here the portal vein filling in very early with the hepatic artery injection, and we can notice how much the hepatic artery is prominent with filling of the portal vein and splenic vein just from the hepatic arterial injection. In this case, we used histoacryl glue, the beta-cyanacrylate glue, which unfortunately diffused not only for the branch but to some other branches, but we can notice complete obliteration of the fistula after injection and the embolization of the glue. Another patient, male patient, 65 years old, underwent Whipple operation for cancer head of pancreas, presented 2 weeks later by severe hematemesis and attacks of melena. Upper GI endoscopy faced by intraluminal blood and blood clots, which could not visualize the source of bleeding. The hemoglobin level dropped 7 grams in 3-6 hours. The patient was carried to the IR suite. We can recognize here the dissecting fusiform aneurysm of the right hepatic artery, which is a replaced right hepatic artery from the superior mesenteric artery. Here and here. What are the treatment options? The treatment option is either to occlude the right hepatic artery by putting coil from, as we said, back door, front door, or to trap the aneurysm by occupying the hepatic artery by the coils distally and proximally. Or another novel solution is to put a stent graft traversing this dissecting aneurysm, but this will be faced by passing the guide wire safely distally across the aneurysm. We succeeded to bypass the wire beyond the stenosis in the beginning of the artery and beyond the aneurysm. And we put a stent graft across, and we can see there is no filling of the pseudoaneurysm, dissecting pseudoaneurysm. The hematemesis is stopped, the hemoglobin level started to rise, and this was a CT scan just weeks after the application of the stent, show patency of the hepatic artery and with no aneurysmal filling. We will go fast into the variceal bleeding using the tips. The indication, as you all know, variceal bleeding. In variceal bleeding, the acute cases, if it is uncontrolled or not responding to medical and endoscopic treatment, or in cases of recurrent bleeding. Contraindication, there's absolute as progressive failure, not related to the bleeding, cavernous thrombosis of the portal vein, effective celiac artery stenosis, right side heart failure, and neoplasm along the course of the presumable shunt. The relative are many. If there is any HCC, hepatic metastasis, and if there is correctable coagulopathy, the sample technique, portal puncture via transjugular approach to the hepatic vein to the portal puncture, balloon dilatation of the tract, stent application, and this is a control showing patent stent. Special consideration regarding tips. If there is port systemic gradient should be kept between 8 and 10 milligrams, 10 millimeter mercury. If still there is variceal perfusion, despite reaching this point, this is a solution that Dr. Ali Farang will be happy with it. In such case, with this large gastric and esophagogastric varices, we can go selectively into the vertex and put some coils and some glue. This, by the way, from previous injections. And this is how the shunt is doing after the embolization, trans-shunt embolization of a gastric varices. Thank you for your listening.
Thank you, Professor Amr, for this elegant lecture. We enjoyed it very much. And I have the honor to introduce our last speaker in this session, Professor Ahmed Hashim from Saudi Arabia, who will speak about anticoagulation in upper GI bleeding.
بسم الله الرحمن الرحيم. Good evening, dear professors and dear colleagues. It's my pleasure to be with you today. Almost we are about to finish the second day of the meeting, and actually it's till now it's a success. The kind of the presentations we have was excellent. I saw my colleague Amr Nasif, who I didn't meet almost 20 years So it was actually a nice opportunity. I hope that you can see my screen.
Yes, Professor.
So let us talk about the management of antithrombotic agents in patients with upper GI bleeding. Actually, the use of antithrombotics and antiplatelets and anticoagulants are increasing nowadays, mostly in patients with old age, with frequent occurrence of upper GI bleeding, which is a cause, an important cause for hospital admission. And the balance between the need for the anticoagulants and then, on the other hand, to stop the anticoagulants to treat bleeding is really should be judicial. Antithrombotics are either the antiplatelets or the anticoagulants, which are used for primary and secondary prevention of cardiovascular diseases. Antiplatelets include many agents, namely aspirin, Plavix, Perlenta, and others. However, the commonest we use in our practice is aspirin, the low dose, Plavix, Perlenta, and Agrastat, and the duration of action varies from a few seconds like Agrastat up to 1 week like aspirin. On the other hand, we have the anticoagulants, which work on the coagulation pathway. Our old friend is the warfarin, the Coumadin. Then we have the IV, unfractionated, as well as low molecular weight heparin. And we have the new anticoagulants, the new oral anticoagulants, which are non-vitamin K dependent. We have the the first of them introduced in the market was Paradexa, which is a direct thrombin inhibitor, dabigatran, and direct factor X inhibitor, which are the Varoxaban, Zeberto, Eliquis, and Savizia. The common use in practice is Coumadin, heparins, Xarelto, Eliquis, and Paradexa. I'll use that trade name because actually go into the scientific name sometimes is not or not come easily in our mind. When we use these antithrombotics, usually we use in cases of coronary artery disease, cerebrovascular accidents, peripheral vascular disease, AF, vascular venous thromboembolism, hypercoagulable states, and mechanical heart valve. Sometimes we use simply aspirin, or dual antiplatelets, and sometimes use triple anticoagulants like those with mechanical heart valves. So this increase the burden if GI bleeding occurs. Cases are either low risk or high risk regarding the stopping of anticoagulant related to the underlying thromboembolic disease. Low risk cases include solitary AF, أيام بس عنده AF, nothing more, or an attack of DVD more than 3 months, coronary artery stent more than 12 months, or non-drug eluting stent. On the other hand, we have high risk cases for stopping thromboembolic drugs, AF with other factors, multiple DVTs, or drug-eluting stents less than 12 months. Let us have throw more light on AF. As we said, isolated AF is a low risk of stroke, so stoppage of anticoagulants can be. However, if there are associated factors like these CH2 DS2, sorry, if you can calculate the score, which is CH2, DS2, and vascular, you can calculate the risk. We can give single score for congestive heart failure, for hypertension, for diabetes, for stroke, and we give 2 points if the age is above 75. Single point is given to vascular disease, age 65 to 74, or underlying cerebrovascular accident. So either you have a low-risk patient with isolated AF. If there is an additive factors like hypertension, like diabetes, this is a high risk for stoppage the anticoagulants. So if you are talking about endoscopic procedure, we can classify it into either urgent, like variceal or non-variceal GI bleeding, or elective, which is classified either low risk or high risk. This session is about urgent GI bleeding, so we will talk about variceal and non-variceal upper GI bleeding. So when evaluating your case, you should have a strategy regarding the severity of bleeding, including hemodynamic instability, the bleeding site and the etiology, antithrombotic agents the patient is receiving, which one, and the dose, the timing, the last one taken, assessment of residual coagulation status, special care to be given for patients with liver or kidney affection, as the new oral anticoagulants are mostly excreted by the kidney. Importantly, to remember this, we say hashtag, no, we need to say hash T. Hash stands for hold further doses of anticoagulants. So this is H, stop the anticoagulant immediately, and consider the anti-dot. A stands for the anti-dot. So what is the anti-dot we have? We have the fresh frozen plasma. It's nice. However, it's against is you need to have a large volume to have a correction of the anticoagulant. The use of unactivated prothrombin complex, whether 3-factor or 4-factor. 3 factors has little or no factor 7. We have the activated prothrombin complex concentrate, which including the 4 factors, or you can have recombinant factor 7. To continue, we need to have a supportive measure by volume sustative. Inotropes may be needed. We need to have a hemostatic measure like tranexamic acid, transfusion, and Mo talk about not to over transfuse our patients, and endoscopy is needed to investigate for bleeding source. So whenever we have a case with bleeding using an anticoagulant, remember the hash T. Importantly, regarding when to stop the anticoagulants, how to reverse, and when to restart. Importantly, like Maali showed us, these are the special, the patterns of the bleeding ulcers we have as per the forced classification. Importantly to realize that cases with spurting blood, oozing, non-bleeding visible vessels, and adherent clot is really dangerous, and you must stop the anticoagulants and you think thoroughly before you restart. On the other hand, clean-based ulcer, 4C3 or 2C, like flat spot in the ulcer crater, you can restart your antiplatelets directly. So, in patients using antiplatelets, namely aspirin and Plavix, non-steroidal already discussed by Dr. Maali. So if the antiplatelet is used for primary cerebrovascular or cardiovascular prevention, withhold aspirin, re-evaluate the risk and benefit of restarting aspirin. And importantly to mention that currently aspirin is not recommended for primary prevention. Most of our patients who come, I have just one yesterday in the clinic who said that I am taking aspirin. Why? They said that routinely after the age of 40 or 45, you should take an aspirin despite there is no history of coronary events. He's not diabetic, not dyslipidemic, even if he's taking it as a primary prevention. So most of the guidelines now say there is no place for aspirin for primary prevention, and it should be stopped and not to be restarted, as in this case the side effects overweigh the benefit. On the other hand, it's used for secondary cardiovascular prevention. Aspirin, we will withhold it If the patient is taking dual antiplatelets like aspirin and Plavix, withhold Plavix and you can continue aspirin. If there is high risk of endoscopic stigmata like Forest 1A, B, 2A, and 2B, you can restart aspirin on the third day following endoscopy and discuss with the cardiologist if he needs the dual antiplatelet, if he has a drug-eluting stents or recent insertion of a bear stent. On the other hand, if the patient has a low risk, according to Forest, you can restart aspirin immediately. So aspirin is not that dangerous as we think in the past. We can do polypectomy even while the patient is using aspirin, but care should be taken if there is an active bleeding ulcer. What about vitamin K antagonist? If there is an active upper GI bleeding without hemodynamic instability, we need to stop the comedine and we can revert the anticoagulation. How to revert? By vitamin K, 5 to 10 milligram IV over 30 minutes, and you can give the prothrombin concentrate complex. If the INR recheck after 20 to 30 minutes, then you can go for urgent endoscopy and restart vitamin K in 7 days. If there is bleeding without hemodynamic compromise, you should hold the vitamin K, and here you need to hold comedine, reverse anticoagulation, and go for INR and go for endoscopy if the INR is corrected. So actually, in all these cases, we go for endoscopy. It is urgent if there is an active bleeding. It can be delayed for some time if the patient without compromise. Lastly, for the new oral anticoagulants, for self-limited bleeding, we can restart it at once. However, if there is a life-threatening bleeding, we need to revert them. There are available in the market their antidote, but the problem is in the price. The price per ampoule is almost $3,000. So I think it's hard. If there is massive bleeding, we can go for hemodialysis or give the prothrombin concentrate complex. If there is prolonged stoppage, you can think about heparin bridge. What about cirrhosis? Patients with liver cirrhosis actually has a problem in their coagulation parameters. All of us thought or think that patients with cirrhosis has bleeding tendency. I agree, due to low platelets and low factor 2, 7, 9, and 10. On the other hand, they are liable for thrombosis due to deficiency of protein S and protein C. So they have bleeding tendency as well as thrombotic tendency. In cases doing banding for patients with life-threatening emergency, risk of delayed hemorrhage is there, and rebleeding due to band-induced ulcers has been found to occur in 14%. Multivariant analysis found no increased risk of bleeding in those on aspirin, although this applied to only 8 out of 600 patients. There have been no studies of the risk of hemorrhage following variceal banding in patients on Plavix or direct or new oral anticoagulants, and it is wise to be stopped in this high-risk group. So in summary, the most important is to consult the cardiologist. This is a multidisciplinary approach, and the cardiologists usually need to rush for the anticoagulants, and you are afraid to stop, and the ICU doctor in between. So sit with your colleagues, take the decision for the best output. In clinically significant GI bleeding, it will not be possible to stop antithrombotics in a timely fashion. reversal of anticoagulants, namely warfarin and NUAC, is mandated. When possible, endoscopy should be deferred for at least 24 hours. Endoscopists should ensure that the patient is aware that endoscopic procedure carries an increased risk of iatrogenic complication or bleeding and should be documented. Thank you all.
Thank you very much, Professor Ahmed, for very intelligent and illustrative talk and for sticking to the time. I think we are behind schedule, so we will start immediately the next session. And I call Professor Siraj Zakaria and Professor Ali Gaballa to chair the next session. تفضل.
Thanks.